Good morning. Myself, Dr. Salman. I am a senior resident in Department of Orthopedics. And today's our topic of discussion is shaft of femur fracture. Introduction about the femur bone. It is the longest and the strongest bone in the body. It bears weight, transmits weight to the tibia, and it's padded up by muscles of the thigh. And confined to the shaft of femur, it is a 5 centimeter distal to the lesser trochanter and 5 centimeter proximal to the adductor tubercle. Most common mode of injury in shaft of femur fracture is one, high energy trauma, or two, low energy trauma, that is mostly slip and fall. So high energy trauma occurs due to fall from height and motor vehicle accident. Most commonly, it occurs in the younger individuals. And low energy trauma occurs in the elderly individual, most commonly because of the bone, which is osteoporotic, most commonly because of postmenopausal symptoms. And also it occurs in long-term bisphosphonates therapy. Types of the fracture should be known by all individual to go to the next step of confined to the shaft of femur fracture. So, depending on the pattern of the fracture, the types are 1. Transverse, 2. Linear, 3. Oblique and it is non-displaced, and 4. It is oblique and displaced fracture, and 5 is spiral fracture, and 6 is green sticks fracture, 7 is comminuted fracture, and 4th one is avulsion fracture. To differentiate between the oblique displaced and the spiral fracture, when the shaft fragment is very sharp at the each end, it is known as a spiral fracture. And green stick fracture is a unicortical fracture. That is the one cortex, which is the anterior cortex or the posterior cortex or the medial cortex or the lateral cortex only will be fractured. Comminuted fracture occurs in 2, 3, 4 or as well as the fragments depending on the force of injury which is impacted into the bone. Winquist and Hansen's classification is there for the shaft of femur fracture, which is followed universally all around the world. That according to Winquist and Hansen, type 0 is no comminution, whether the fracture will be oblique or spiral or transverse depending on the pattern, but the fracture won't have any comminution from the shaft. Type 1 is the small butterfly fragment, as you can see here, which is coming in the shaft. And type 2 is large butterfly fragment, but more than 50% of cortical contact between major proximal fragments. Here in this image, we can clearly see that the fracture is having a butterfly fragment and it is displaced more than 50% cortical contact will be present. And the type 3 is large butterfly fragment with less than 50% of the cortical contact, where you can see more than 50% of the bone is coming out of the fracture, but only less than 50% is in contact. And type 4 is a segmental comminution fracture where there is no contact between the major proximal and the distal fragments. So type 4 is segmental. Segmental means the bone is fractured in more than one side of the continuity. So the bone will be in parts of the segment. There will be 1, 2, 3 or multiple fragments of the bone which is fractured according to the segments. So that is type 4 of the segmental comminution of the fracture. So as we have seen in most common fractures, the shaft of femur is also a most common fracture and the clinical findings are common for all the fractures mostly. Patient comes with the symptom of most commonly of pain, swelling, redness and deformity, and when we examine the patient, we will have tenderness over the shaft of the femur. So shaft is palpated mostly in the lateral side. So when we palpate from the head, neck and towards the intertrochanteric region and from the subtrochanteric region to the shaft of the femur, we will have so much severe tenderness for the patient, and then we can find out the patient is having a fracture in her or his shaft of femur. And Because the continuity of the bone is lost, there will be loss of function on that limb. And in severe scenarios, in case whether it is an open fracture and whether it is a severe high grade injury to the shaft of the femur, the patient will be having her or his injury to the nerve and vascular structures. So neurovascular structure injuries should be ruled out at the time of the injury. So medico-legally, if the patient is having neurovascular injury and if it is not noted, when the patient is in the operation theater and post-operatively, if there is neurovascular injury, it may lead to more severe consequences for the operating person. So always and always, we should always see for the neurovascular injuries and we should rule out neurovascular injuries at the time of presentation and at the time of the doctor examining the patient in the emergency department. So always first we take a radiological investigation for the patient. So X-ray thigh or the femur, AP and lateral view is taken. So to know the normal common radiological indices. So this is the head of the femur and this is the neck of the femur and this is the intertrochanteric region or called as the intertrochanteric crest, and this part is the greater trochanter and this one is the lesser trochanter and this is a shaft. So it continues in the AP view to the distal aspect, and this is the distal shaft of the femur and this is the patella in the proper AP view, and this is medial condyle and this one is the lateral condyle. So this is how a patient presents to us in shaft of femur fracture. So this is the AP view of the shaft of femur and this is the lateral view. So in reduction, we should see whether the fracture is displaced laterally or medially in the AP view or anteriorly or posteriorly in the lateral views. Management. We shouldn't always jump up to the operative management in case of shaft of femur fractures. These fractures are more delirious and more cumbersome to handle if the patient is having complications. So always and always A, B, C, D, E comes to us as a normal criteria. So A is for airway and cervical spine control. So first we should assess and then we should diagnose and then we should intervene for what we are going to stabilize the patient. So in airway, always and always we should assess whether there is inline immobilization, and always we should ask the patient about their demographic details to look, listen and feel what injury the patient will have, and to diagnose if the patient is not able to do it, if the patient is having any airway obstruction or if the patient is having any apnea, he or she will have stridor or any additional sounds which is present. So always we should interrupt and intervene to the patient with the collar and airway maneuvers like a bougie or a intubation and airway adjuncts. And B is breathing. Breathing is measured by a simple oxygen saturation which is present in our emergency department with the SpO2 probe. When we are seeing the saturation which is dropping less than 92 or 90, we should always and always intervene and we should see through that the patient is having adequate oxygenation support. So that is the first thing. Second thing is the breathing pattern. Whether the breathing pattern is cardiothoracic or thoraco-abdominal or abdominothoracic. So if the breathing pattern is thoraco-abdominal for male, it is normal. And if the breathing pattern is abdominothoracic for male, it is normal. So in case of female having abdominothoracic, in case the female is having abdominothoracic breathing, it is most commonly very difficult for us to manage. So we should always diagnose immediately with chest injuries like hemothorax, pneumothorax, open pneumothorax or failed chest. So intervention is most commonly by oxygenation and needle thoracocentesis, chest drain, and mechanical ventilation. C is circulation and hemorrhage control. So this one is easily monitored by a normal blood pressure monitoring with sphygmomanometer and heart rate by our probe, and capillary refill time, which should be adequate, which should be less than 3 seconds, and the skin color of the patient, if it is normal, pink, and if it is not, and it is not normal, if it is cyanosed, it will become into a venous color, that is a purple color, and it should be noted. And it will diagnose whether the patient is having any bleeding into the thorax, abdomen, pelvis, thighs, or any external organs. An intervention should be always done by the IV cannula, fluid boluses, fast scan, that is focused ultrasound sonographic scan, and surgical assessment to rule out the debilitations, and CT if the patient is stable and if you can stabilize the patient and move away to the radiological department. D is disability and neurological function, where we see the Glasgow Coma score and pupillary reaction and limb movements. And diagnosis is by intracerebral bleed and the spinal injury. We diagnose with the disability of the patient. And intervention is we are going to do a CT brain and neurological assessment to the patient. Exposure and environmental control, we are going to do log roll with 2 or 3 multiple person in a similar given manner, and spinal tenderness or a step to rule out the spinal injury, and TR examination to rule out any abdominal injury or intestinal injury, along with that the central dislocation of the hip and the core temperature of the patient. Diagnosis for the spinal injury and hypothermia, as I said, and intervention when the patient is stable, we can shift him to take a X-ray, CT, and to rule out hypothermia, we are going to provide a warm blanket for the patient. So, if we diagnose a patient with the shaft of femur fracture, always we are going to immobilize the limb and stabilize the limb with a Thomas splint. So, this is the Thomas splint, where the outer metal oval ring is present, and there is a 2-inch angulation in the outer bar. So with the angulation, we can find this is the outer bar and this one is the inner bar, and these are called as the side bars. So this outer angulation is present to accommodate the greater trochanter of the femur, and this is how we are going to stabilize the patient with the Thomas splint. So first, adequate padding should be given in all the areas where the patient is going to have a connection or a touch with the ring. So adequate soft bandaging should be applied. Then a metal oval ring should be inserted through the foot towards the leg and the knee and to the thigh and to the couch. So this metal ring should accommodate into the groin and the inner bar and the outer bar, and this is the distal length of the Thomas splint, and it should be applied to the traction foot, and the adequate traction should be given from upward to the downward force. So with this force, there will be proper alignment of the fracture, and the fracture fragments won't get displaced until the patient is stabilized, and the fractures, when it is aligned, so muscle impingement or neurovascular injuries can be stopped, so that the patient is going to have a proper alignment of the fracture. So in case the patient is fit for surgery and the patient can be taken up for surgery, and the patient is having a high energy trauma in case of young adult, we can do a closed reduction of the fracture. So in this X-ray, we can see that the fracture is displaced anteriorly while seen in the lateral view. So this is a proximal femoral nail where the system of PFN A2 is used to fix the fracture. So in this fracture, a nail, or commonly called as a rod, is inserted, and a proximal femur helical blade is placed into the neck through the head of the femur, and the distal interlocking screws are placed. And this is a one more case where in a AP and lateral view, in a AP view, we can just see there is no displacement of the fracture and it looks like normal. But in close observation, we can easily see that the fracture fragments are overheaded. So this is what is the important of taking multiple views in case of orthopedic fractures. So if the patient is done with the lateral view, you can clearly see that the fracture is displaced and healing. So this patient is post-op for surgery and a nail is passed through the intramedullary canal, and two proximal locking screws and distal locking screws are placed. This is the anteroposterior view and this is the lateral view after the fracture is nicely united. And one more thing to observe between this patient and this patient is the working length of the nail should be observed. So the working length is when the fracture is little bit proximal in the shaft, we should always go for the proximal femur nail so that it hits onto the neck and to the head. And in case of this fracture, it is in the middle 1/3 to the distal 1/3 junction of the shaft of the femur. So in this fracture, we can go for a normal femoral nail with the two proximal locking bolts and two distal locking bolts. So the site of the shaft of the femur also decides the type of the intramedullary device which we are using for the fracture. So open fractures, it's totally a different case. So in case of open fractures, we classify the open fractures with Costello-Anderson classification. The type 1, which is less than 5 centimeter of the wound or 1 or 2 centimeter of the wound, and type 2 is the 2 to 5 centimeter of the wound, and type 3 is 5 to 10 centimeter, more than 10 centimeter of the wound, where in more than 10 centimeter, it is classified into type 3A, 3B and 3C. Type 3A is when the periosteum is intact and it is exposed to the outer environment, but the wound is more than 10 centimeter. And type 3B is the periosteum is totally avulsed, but the neurovascular injury has not yet happened. And type 3C is the neurovascular injury has happened and patient also needs a neurovascular intervention should be attempted at the time of fracture fixation. So this is a case of open shaft of femur fracture where the external fixator has been fixed to the fracture and double rod has been kept. And this is how an animatic view looks. So this is an AP view where we can see the fracture is displaced medially. So we are keeping 3 pins proximally and 3 pins distally, and the fracture alignment is placed. And after the fracture alignment is placed, the external fixators are kept. And after 6 weeks, and after as soon as the wound is getting healed nicely, we can remove the external fixator devices and we can go through with the intramedullary fixation of the fracture. So complication of shaft of femur fracture is more common in nowadays because of the mode of injuries which we come through day to day. So it is divided into early and late complication. Early complication is most severe hemorrhagic shock and fat embolism, which causes the respiratory distress to the patient, and injury to the femoral artery and the sciatic nerve, that is a neurovascular structure which runs through the posterior compartment of the thigh and it ends in the knee. So in case of hemorrhagic shock is classified into 4 types, class 1, 2, 3 and 4, where we see the patient, we examine the patient and we see the blood loss, heart rate, BP, pulse pressure, respiratory rate and urine output and the CNS examination of the patient. With class 1, blood loss percentage is 15% or less. That is, according to the ml, it is less than 750 ml of the blood which is lost from the patient's total blood volume. And class 2 is 750 to 1500 ml, that is nearly 1.5 liters. which loses up to 15% to 30% in case of blood loss of the blood volume. Class 3 is 1500 ml to 2000 ml, that is 30 to 40% of the patient's blood. And class 4 is more than 2 liters, that is 40% of the blood is lost, and there should be massive blood transfusion attempted immediately when the patient is having these kind of injuries. So heart rate in class 1 it is less than 100 beats per minute, and class 2 it is more than 100 beats per minute, and class 3 it is more than 120 beats per minute, and class 4 it is more than 140 beats per minute. And BP in case of class 1 and class 2 will be normal, and class 3 it will decrease, and class 4 there will be severe blood pressure lowering. And pulse pressure, which is the difference between the two pressures in the upper and lower limb, should be normal in case of class 1, and class 2, 3 and 4 it will be decreased. Respiratory rate will be 14 to 20, which is equal more or less normal in case of class 1. In class 2 it will be 20 to 30, class 3 it will be 30 to 40, and class 4 there will be more than 35 respirations per minute. And urine output is the most important parameter we often tend to miss. So urine output will be more than 30 in case of class 1, 30 ml per hour, and class 2 it is 20 to 30, class 3 it is 5 to 50, and class 4 there will be no total urine output present. So always and always when a patient comes to the emergency department, we should catheterize the patient and we should start measuring the urine output. And in case of central nervous system examination, there will be slight anxiousness present in class 1 patients. In class 2 patients, the patient will be mildly anxious. In class 3, the patient will be anxious and confused. And class 4, the patient will be lethargic, confused, and he won't respond to the command of us. And even the Glasgow Coma score may drop to 3 in scale. So, fat embolism is another immediate or the early complication which you come through day by day, and it should be noted that the patient is going for fat embolism, and it should be thoroughly examined immediately, and it should be treated immediately as well. So, in case of fat embolism, what is a fat embolism is there is a presence of fat globules in lung parenchyma and peripheral circulation, and the patient presents within 24 to 72 hours of the time of injury, and rarely it is less than 12 hours or more than 2 weeks. The classical triad of the fat embolism is 1. Respiratory changes, 2. Neurological abnormalities, 3. Petechial rash, which leads to the deliberate acute respiratory distress syndrome. So Gerd and Wilson came out with a criteria to rule out whether the patient is having fat embolism or not. So their 3 major criteria are respiratory distress, cerebral symptoms in non-head injury patients, and petechial rashes. These 3 are the major criteria. And minor criteria is 1. Tachycardia of more than 110 beats per minute, fever, which is more than 38.5 degrees centigrade, jaundice, renal changes, retinal changes with retinal petechial hemorrhages, and drop in the hemoglobin of the patient, new onset thrombocytopenia where the platelet level is decreased below 1.5 lakhs, and elevated erythrocyte sedimentation rate, and whether there is any fat macroglobulinemia, which we are going to find out with the total protein blood investigation. So, Gerd and Wilson have told us that 2 major criteria or 1 major criteria with 4 minor criteria suggest that the patient is having a fat embolism syndrome and it should be treated immediately. So, what is acute respiratory distress syndrome? Acute respiratory distress syndrome presents with early sign of dyspnea, which is difficulty in breathing, tachypnea when the heart rate is more, with the patient having a respiratory rate more, and hypoxemia or the less partial pressure of oxygen less than 60 mm of mercury. And the other sign of acute respiratory distress syndrome is retinopathy, which is often seen by ophthalmology examination with the cotton wool spots, and lipiduria, fever, disseminated intravascular coagulation, myocardial ischemia, anemia, thrombocytopenia, and hypocalcemia. So this is how a chest X-ray of the patient presenting with the acute respiratory distress syndrome will be. One, there will be a zoosperm appearance. When we take a chest X-ray PA view, there will be no vacant areas in all the lobes. There will be full of snowstorm appearance which is present, which is also known as a ground glass appearance. So this should be always noted up. And when we are suspecting fat embolism syndrome, immediately patient should be stabilized with the Thomas plane or with the normal device, whatever we do. And the patient should be shifted to the radiological department to do a chest X-ray. And if feasible, the patient can be underwent with the high resolutional CT scan, that is HRCT chest. And we are going to rule out whether the patient is having any acute respiratory distress syndrome with these parameters. And the late complications, as far as all the fractures are concerned, the patient will may have, if the patient is not fixed with the fracture, and because of the overriding of the bones, the patient may end up with the non-union or a malunion or a delayed union, which is less than 6 months, and there will be acute limb shortening present if the patient is having more non-union or a non-union between both the fragments. And in case the patient presents to us very late, it will end up in knee stiffness because of the loss of the bone. Thank you. So, for summing up, I will just go through to the most important slides in my presentation. So, these are the most important things we should know in case the patient is presenting us to the shaft of femur fracture. So, normally, in case of undergraduate level, candidates should know what is a shaft of femur, which is extending from 5 centimeter distal to the lesser trochanter to 5 centimeter proximal to the adductor tubercle, and this part is called as a femoral shaft. And most common injuries are high energy trauma and low energy trauma injuries, and the types of fracture should be known by all the candidates, and we should also be able to treat the fractures with the type of fracture which is there, and the Winker and Hansen classification with all the 4 classification with the 5 types, and the diagnosis with the proper AP view, what is a proper AP view and what is a proper lateral view in case of a fracture, and how will you resuscitate a patient according to ATLS protocol. We are going to do A, B, C, D and E, which is a thumb rule for all the medical graduate present to know the ABCDE of a fracture fixation, and a reduction with the stabilization with the Thomas splint, and how to measure the Thomas splint, and how to apply a Thomas splint, and how to stabilize the shaft of femur with the Thomas splint is very important for us to know, and how to fix a fracture in case of closed fracture and open fracture. And complication, most common complications with the hemorrhagic shock and fat embolism syndrome should be known by everyone, and how to diagnose a hemorrhagic shock and how to diagnose a fat embolism with the specific tabular columns and criteria should be known by all the people over here. And the fat embolism syndrome should be diagnosed with the Gerd-Wilson's criteria. So the Gerd-Wilson's with 2 major criteria and 4 minor criteria should be known by everyone. And the acute respiratory distress syndrome with the 3 complications of early signs with the dyspnea, tachypnea, hypoxemia, and partial pressure of O2 should be known, and the other signs. And most common and most easiest way to find out acute respiratory distress syndrome with the snowstorm appearance or a ground glass appearance should be known by everyone. Thank you.